Okay, let's get to it. This is really exciting. My first introduction will be to an extraordinary colleague, a leader in his field for sure. His name is Dr. John Flannery. John, if you could raise your arm, please. John is the medical director of the Musculoskeletal. I say that so well now. Musculoskeletal. I had a hard time getting my tongue around that when I first came here. And the multi-system rehab program, and has guided the program for the last 13 years, building it up from one physician when he started up to a team of a dozen. Toronto Rehab's Musculoskeletal, I'm going to say MSK, that's the short form, MSK and multi-system rehab program has recently shifted its focus from knees and hips replacements, arthritic pain and trauma, and now is more focused on chronic pain. 9 out of 10 patients now come to the program, to Toronto Rehab, with pain as the primary issue, and each year our outpatient program sees over 20,000 outpatient visits. 20,000 pain-related outpatient visits. Dr. Flannery has elevated the stature of the program, has placed in a leadership role here in the GTA, provincially, nationally, and internationally. In 2014, this is quite a recognition, quite an honor, and we all take pride in your accomplishments. In 2014, he had the distinction of being named the best physical medicine and rehab doctor in Toronto by Toronto Life magazine. John? I'm going to leave my Advil just in case up here. Thank you.
Thanks. Thanks. Is this on, Matt? Thanks, Cindy. I'll use my indoor and outdoor voice. And I have a trusted assistant, Jan, who's going to move the slides for me. So thank you, everybody. It has been an honor to have worked at Toronto Rehab for the last 13 years. I've had the pleasure of really creating and molding a program, and you'll get to hear a couple of my first draft picks later on present. Andrea Ferlin, you'll get a chance to realize she was my first fellow, and Dinesh Kumbari transferred from the University of McMaster to us, and he's my first guy that I've sponsored to do a PhD, and he's going to talk to you about muscle pain, and that's the orphaned muscle or system in our body. No one looks after muscles, right? We have orthopedic surgeons to look after bones. We have neurosurgeons to look after, the neurologic system. We have neurologists who look after nerves, but no one looks after muscles. And muscles are incredibly important. So stay tuned. He's going to give you some excellent information. So I'm going to speak to you a little bit about pain and central sensitization. Does anybody here, have they ever heard the term central sensitization? Just put up your hand, please. So, we got a steep learning curve, I can see. And so it's really important because this is one of the biggest reasons we have chronic pain. We don't understand this. So I'm going to give you a little primer on what we're going to talk about. If you move the next slide. So Cindy's already talked about this. Leading musculoskeletal rehab multi-system program. Actually a little higher than 18,000, 20,000. We also have 60 beds that look after these joint replacements, that look after these hip fractures. We also have oncology beds, and then we have trauma as well. So we get the whole gamut of patients that come through our door. But that's just a small portion of their life. They're with us for about 20 to 30 days. A little bit shorter than our stroke programs, where they're 60 days or maybe as long as 90. But so they're with us for a short bit. So our outpatient process, getting these people back functioning, is incredibly important. So our outpatient program is grown. So it was just me when I started, and now we got 12 docs. So we've actually been able to grow. And growing a chronic pain program is really hard. Really hard. And the reason it's so hard, we're going to hear about it, because the central sensitization isn't understood. And so when you come in and you start to have pain from an arthritic joint or an arthritic shoulder or back pain, and then it starts to grow and migrate and change, what the heck's going on? And so understanding that is very, very important. Echo Super Hub. So Educational vehicles to help people understand are one of the important things. Sanjeev Arora is a lovely hepatologist down in New Mexico. He came up with this brilliant idea of teaching people how to manage hepatitis C in rural New Mexico because they couldn't manage it. And people were literally dying to get to see Sanjeev in his, in Albuquerque. And so Albuquerque, the state itself, or the state of New Mexico, was 49th out of 50 for their rates of health with respect to the liver. And he took it from 49th to 2nd. That's a huge improvement, and he did it through Project ECHO, Extension of Community Healthcare Outcomes. Andrew's going to speak a little bit more about that. We were the first to do it in Canada, here at Toronto Rehab, for chronic pain. So we got awarded from the Ministry of Health to do this stuff as a project. We did it so well, they've now asked us to become the super hub trainer for all of the country. And we've got our first one coming up December 12th to 14th, where we're training everybody across Ontario and across Canada. So they're going to have a chance. So we're really quite proud of that, and we'll talk to you more about that process. So hip, right? Everybody got a hip, right? We've all got hips. And sciatica, that big sciatic nerve. We've heard sciatica for the longest time. But sometimes this myofascial stuff that Dinesh is going to talk about, that's actually what goes on the left-hand side, right? Or your right. And it radiates. So these little muscles, this little gluteus minimus or medius or piriformis, they'll radiate all down your leg. And they'll drive you crazy when you're sitting in a car. And you go, oh, it's got to be my sciatic nerve. It has nothing to do with your sciatic nerve. It has everything to do with the muscle. And so people get surgery on their backs. If they also have a bulging disc and you go to the right neurosurgeon, you'll have surgery on your back in seconds. And it'll be great for 6 months. And then it comes back because it's myofascial pain that we haven't educated people because it's an orphaned or a system. Next slide. So here's just yesterday, David Gerling. So Andrea, myself, Dinesh, worked with David. We had him at our national conference on a web base. Dinesh and I were chatting about this. So this is yesterday in the Globe. He's talking about tramadol. And tramadol is one of those medications that slipped underneath Health Canada to not be recognized as an opioid. But it's an opioid. And it has all the same effects of opioids. Just to give you an idea of how we really have to be much more cautious about how we manage things like opioids, how we manage things like marijuana that are going to come along. We have to do proper research. We have to talk about this stuff and understand that we train people. In Canada, the average medical student gets 4 to 10 hours of training on how to manage opioids. 4 to 10. The average vet, 87 hours. Are we crazy? Like, are we absolutely insane? That's what goes on. We give a handgun to a 4-year-old, right? And say, this is opioids, and we don't even show them the safety and say, here's your MD degree, go out and practice. Hence why we have this opioid crisis. Because it's a lot more than just an opioid pill, but it's very easy to give that prescription to someone to manage it. And so Andrew's going to speak a little bit more. This article talks about someone who had shoulder pain, who got put on tramadol because it wasn't an opioid, only to become very debilitated when he tried to get off these opioids. So we'd have to do a much more effective job of managing this. We have to understand it much more effectively. The nerves, we have talked about, and people understand and know all kinds of stuff about the nerves. They do not know the muscle. And because we don't know the muscle well, we need to do more research. We can't understand the nerve stuff particularly well because muscles are everywhere in our body, and they help us propel ourselves and move and do all the actions. Next slide, please. So here's just, this is going to be Nerve Pain 101. And sorry, this is my lovely wife. I'm having to speak to her a little bit of time. Yes, it was very nice music. So, so here are the nerves, right? So on the left-hand side, fire, something sharp, something cold, and it sends a message down, and that's how pain is felt. And so that goes from the periphery into your spinal cord up to your brainstem up to your brain. Everybody's pain, Rick's pain, your pain, Andrew's pain, is felt here. My pain is felt here. It's not saying it's in your head, but that's the final common pathway, right? So this is where the pain goes. And so, oh, that's sharp, pull my hand off. That's hot, pull my hand off, don't do that anymore. And because we get some upregulation, that little blue neuron, that helps us make sure that we understand that it's hot and we go really fast. And then here, down here is just a little low threshold. This is a feather, and that's just touch. So we learn to ignore that. Our clothing we don't feel anymore. Our feet that we're sitting on, our bum that we're sitting on, we ignore all that information that's going up into our systems. So then this is what happens. And you can see all the little firing of the neurons. That's how we communicate. So, next slide. This is what happens in central sensitization. So this upregulation that goes on in the nerve, because we're bombarded with this all the time. And so instead of this, just being painful from, a little prick or pressure, or a slight little something that's going to be sharp, it now feels like you've got a knife, or you've got ants that are crawling all over you. You get hyperalgesia. The normal pain stimulus is exaggerated, and that's really debilitating. Then the same goes on with this little feather, because this little feather now it starts to upregulate as well. It starts to talk to your other nerves. So light touch now starts to become feeling like pain. So this connection there from this mechanical low threshold starts to increase. And then our brain starts to do some really nasty things. It'll lower certain thresholds so it doesn't take as much to cause the pain. And it actually starts to then spontaneously fire because the threshold's been lowered, that it actually starts to cause what's called paroxysms. And so you're sitting here, and all of a sudden, some of your joints start to give you pain. Or this area of discomfort starts to spontaneously talk to your brain. That is not a pleasant experience. And people start to get really anxious and worried. And with anxiety and worry and no plan, then they start to get more and more problematic around their management. They can't go to work. As Cindy was saying, she had to really buck up and take all this stuff and put herself on medications to do that because she's driven. And some people are really driven to a certain point, and that's great. But then she came up with the right solution. But not everybody has that wherewithal. So next slide. So central sensitization, augmentation in the activity of neurons and circuits and pathways caused by increased membrane excitability, so the nerves get even more ready to fire, and synaptic efficacy, so they are ready to fire and fire lots, as well as reduced inhibition. So the stuff to dampen that down is gone. So it fires faster. It's almost like it's seeking this pain. And so in your brain, what we call the homunculus, which is the size of the representation of what the different body parts are, it grows and it expands. And it's eating up all this information, looking for more pain. The net effect recruits previously subthreshold synaptic inputs to nociception, pain, neurons, and generating an increase in augmentation of potential output. So it starts to grow and expand, and it grows and expands. So that little disc that was pushing on the nerve, and then the disc sucked itself back in, and you didn't have a sciatica or pinched nerve, now starts to talk. And that memory gets really big, starts to talk to muscles, and muscles start to really, every time you stretch and you move and you get up, you're starting to have bursts of pain. So pain is no longer coupled to presence. So it's no longer coupled to presence. It just happens. Intensity, so it doesn't have to be a really bad stretch with my glute to cause me pain. It can just be the normal stretch. What the heck's going on? And then the duration of noxious peripheral stimuli. So it lasts after I've stopped the stretch. There's got to be something wrong. There has got to be something wrong. And so you go to a doctor who says, oh, you're fine. Your MRI is fine. You go to another doctor, oh, you're fine. You're really fine. You've done some nerve conduction tests. I go to another doctor, you get some blood work. You're fine. But I'm not fine. I'm in pain. How come? So this is the conundrum that we have. So here's just a summary of all this stuff, and it gets complicated. So you guys are going to be tested on all of these different receptors at the end, and you cannot have dessert until you answer it, right? So inhibitory, right? This inhibition, internodes, they start to disappear. So you lose some of that inhibition, you lower some of the threshold, and some of the nerves that previously never carried pain start to talk to the pain nerves every time that you have something touch you. So you can imagine that gets pretty difficult. And then in the muscle world, your posture, right? So this makes you feel a little bit better because it hurts when I go back here. Well, this now perpetuates it. And so your muscles were designed to be like this, but you're like this. And you go to computers and you work like this. And so all day long you're like this, and it goes, oh, this hurts. And now I start to get numbness and tingling down my hand. It's got to be carpal tunnel syndrome. Well, you go to the doctor, it's not carpal tunnel syndrome. Darn, what the heck's going on? It must be a pinched nerve in my neck. I get an MRI, now I've got an MRI that shows a bunch of aging gray hair. We all age, and all of our discs start to have a little bit of a bulge, or we have a little bit of arthritis. It's part of nature. But instead of listening to this, we start to seek out more. And then we get off work, and then so now the indirect and the direct costs. 1/3 of Canadians are in chronic pain. Huge costs, right? Direct costs just to themselves. No one wants to live in pain. Cost of the system, yes, Jim? So great question. So I think everybody heard that. Essentially, sort of going back to my first point, and this was not a plant from Jim, that is a nice segue into what I'm speaking about. But essentially, you're asking that very important question: is that how did we get here with this pain, right? Because if the broken bone is healed, how come we're still talking about this? And if it's healed, and I can show an X-ray that it's healed, but I've got physiology that shows that this pain is real and still ongoing, we need to have better interspecialty discussions, which goes to the fact that the muscles are an orphaned organ. So we have to have better information so we can actually discuss this. And so we are working with a lot of my orthopedic colleagues, working with neurologists, working with neurosurgeons to try to get that. But that's the difficulty to getting funding, right? So the funding's difficult, which is partly why we're here, to bring up this awareness and help us to be able to help you guys with the management of chronic pain. So thank you, Jim. Next slide. So conditions associated with central sensitization, rheumatoid arthritis. Anybody heard of rheumatoid arthritis? How about osteoarthritis? Anybody suffering from osteoarthritis right now? Yeah, put up your hand. It is common. It's all of us. That's the gray hair. Temporomandibular joints, fibromyalgia, chronic neck pain, whiplash, unilateral epicondylitis, low back pain, degenerative disc disease, shoulder impingement, just about anything that we have. Headaches, Cindy talked about that. Neuropathic pain, CRPS, complex regional pain syndrome. So complex it probably had 3 names in the last 100 years. RSD, causalgia. So these are different things, and we keep reinventing names for these complex things because we really don't understand it. So the list goes on. The point being, there's a lot of things that cause pain and can become really chronic. Next slide, please. Treatment of it. So first, treat the underlying cause. So that's one of the important things. If we can figure out what it is, posture is a huge one. Ergonomic assessment is another huge one because we sit in these positions that perpetuate our pain all day long. Aerobic and resistance exercise. My colleagues, Paul O, over at the cardiac program, has known this benefit for eons. So we have to get people moving. If you are more fit, your pain is less. If you sleep better, your pain is less. If you have better range of motion around the joint, your pain is less. If you have more muscle strength around that pain, around that joint, your pain is less. And if you smoke, please stop smoking, right? Because that's the other thing. So we need to manage these things. Physical therapy, this is what my whole program is about. We do an awful lot of this. We also do a lot of medication changes. Cognitive therapy and stress has really started to become quite apparent that these have some major implications. We've done functional MRIs and can show that people who do this more effectively can actually grow different parts of their brain to manage their pain. So it's not saying it's all in your head and go manage it. It's saying understand how best to manage it. And it's not just one thing, it's many things. So the medication list is there. It'd be very interesting to look at the cannabinoids a little bit more effectively so that we don't have the cannabinoids being the problem in 30 years from now, like opioids were back in the 1980s when we said, let's go push the opioids, which is how it all started. And then emerging NMDA blockade, ketamine, and some other things that we do can all show some benefit. Next slide, please. Non-dermatomal sensory deficits is another component. My colleague, Dr. Angela Malis, who and I, so she was Andrea's supervisor initially. She sat down at dinner to me in 2006 and said, John, I was late for the dinner, so no one wanted to sit with Angela, because Angela is the Greek hurricane. She's a researcher beyond belief, and she's found this stuff years ago. This is 15 years ago. She started to look at non-dermatomal sensory deficits because this is actually this manifestation of central sensitization. So your whole leg, even though you have a small injury, your whole leg starts to feel numb. That's bizarre. That's got to have something. And so, Jim, we haven't got the research to show that. We've got the evidence that it's there. And it's found in quadratomal, so a whole hindquarter or forequarter or half your body. That's not how the nerve should work. Seems even more common as a positive. So it's a gain with allodynia, or sometimes it can be negative with loss, and we manage that differently when we get there. And it's associated with a poor outcome. So next slide. I'm done. So the point being, this is complicated. It spans a whole bunch of different disciplines. We need some support in how to manage it. We've got lots of emerging stuff that can really be helpful. Education is part of that. So if we can educate people through our pain college, that would be wonderful because we can get the masses out. Andrea's done some work in this already with her opioid manager, right? It's at your tables, as well as my opioid manager as well. So we've got lots of activities that we can improve on.